Hello, am I audible? Hello, guys, am I audible? Okay. So, let's start in 2 minutes. Okay. Actually, the thing is, I've not been feeling well. So I've been that's the reason why there was a delay in class. I don't know what's up with me. Maybe COVID ho hi gaya finally. Because from the past 4-5 days I've been very sick. So आज भी I'm very weak, but let's see, let's do this together. Okay, आज गाइनिंग से शुरू करते हैं. Let's start with गाइनिंग और फिर हम लोग ओबी से खत्म करेंगे, ठीक है? I am speaking in English. Mathan Raj, yes, I am speaking in English. See, mostly my teaching is in English. I don't think anybody who does not understand English can have a problem with my teaching because जो भी मैं पढ़ाती हूँ वो English में ही पढ़ाती हूँ. But in between, of course, I'm going to speak in Hindi. Okay, Mathan? Yeah, thank you, Dr. Pal. So let's wait for 2 more minutes for everybody to join in and then let's start. Because वरना मैं faint हो जाऊंगी. Okay, so how we are going to do this is, uh, since this is a rapid revision, we'll just go through all the topics, okay? Topics like, let's start with embryology, then go to menstrual cycle, then go to issues with puberty, okay? So I think we can start now. Should we start? Should we start? Yeah, okay. So let's start. Okay. So the first thing that we will be discussing today will be the embryology. Okay. So basically, embryology in when you take we are talking about an embryo that is getting formed inside the pregnant lady, right? तो जब ये embryo बनता है, the embryo sex determination, right? It is done by the SRY gene, as written here. It is done by the SRY gene. So if there is a present which is present on the short arm of Y chromosome, okay, short arm of Y chromosome. So the sex determination, जो sex determination है मतलब कि male या female होगी, that is done by your SRY gene and that is present on the Y chromosome. तो Y chromosome बस males में होता है, right? XY is for males, right? XY is for males and XX is for females. So the SRY chromosome, SRY gene is only present in males, right? So agar the chromosome is XX, then there will be no presence of SRY gene, right? If there is a female chromosome that is XX, then there will be no presence of SRY gene. That's why she will automatically be female. Okay? Do you understand it? We will start with gynae today. Okay, I hope this is clear to you. Wait, let me just make sure that this is Okay. So basically, we will start with gynae, okay, and then we will finish with OB. But we'll do gynae today. Yeah. Is this expanded enough? Is this expanded enough? Can you see it? Yes, I'll discuss clinical questions too. I actually have questions today. Okay. So, like I said, your sex determination is done by the SRY gene and it is present on the short arm of Y chromosome. So, if the embryo does not have Y chromosome, automatically there is no SRY gene and the sex will be female for that. Okay, and the best investigation of choice for sex determination, again, karyotyping is the best investigation for sex determination, because then you'll come to know whether it's XX, XY, XXY, right? So, are you guys with me? Can I get a yes? So, if SRY gene is present, right? Like if this gene is present, testis is formed, right? We know about testis, and this is formed. Testis are nothing but the male gonads, and they are formed in the 7th week of pregnancy. Okay, and what do they produce? What do testis produce? They produce Sertoli cells and Leydig cells, right? What do you get from Sertoli cells? You get anti-Mullerian hormone. So we also have this Mullerian ducts, right? So if Mullerian ducts are present, I think you remember our gynae image-based session where we were speaking about Mullerian agenesis, right? We spoke about Mullerian agenesis then. So when we spoke about Mullerian agenesis, we were telling about how the uterus is formed by the Mullerian ducts, right? So agar Sertoli cell is present, right? If testis is formed and you have Sertoli cells, they secrete an anti-Mullerian hormone. तो इससे क्या होता है? The Mullerian duct regresses in the sense कि जो duct रहता है ना, जिससे यूट्रस और फैलोपियन ट्यूब अपर पार्ट ऑफ वजाइना बनता है, वो रिग्रेस हो जाता है, इट गोज अवे, एंड देन it is also responsible for the abdominal descents of testis. Testis पहले abdomen में रहते हैं, right? Then they go down all the way to the groin region for the male, right? तो उसकी वजह से ही like the anti-Mullerian hormone is responsible for this. See, it is given. I am discussing about one in different books. It is given different ways. When is testis developed, and when is the Sertoli cell? When will the Sertoli cell secrete testosterone? No, anti-Mullerian hormone. It's up to you. What I've written is I've found this in one book and I've written that. ठीक है, तो आपकी मर्जी है, आप फॉलो कर सकते हो. Okay, so let's go to, so Sertoli cells will secrete anti-Mullerian hormone, and we also have Leydig cells. तो Leydig cells आपको पता है, they secrete testosterone, right? What will testosterone do? So your testosterone will actually, it will increase the size of the Wolffian duct. It will cause development of Wolffian ducts. Okay, so what happens? Wolffian duct will give rise to 4 things. What does it give rise to? Can you tell me? It gives rise to, can you tell me what does the Wolffian duct gives rise to? Anybody who's listening, can you tell me what does the Wolffian duct gives rise to? Seminal vesicles, very good. Seminal vesicles. Epididymis. Yeah. Then what else? Vas deferens and ejaculatory duct. Okay. So your Wolffian ducts gives rise to these 4 things. you can remember it as seed. So that is your seminal vesicles, your epididymis, your ejaculatory duct, and your vas deferens, right? So this is what Wolffian ducts gives rise to, but it also gives rise to an appendix of the epididymis, right? Formed by the Wolffian duct. Okay, you don't have to remember this. This is just some extra knowledge. They usually don't ask you about this. So your Wolffian ducts give rise to appendix of epididymis. It also gives rise to the testosterone, also gives rise to your male external genitalia, and it is also responsible for scrotal descent of testis. So your abdominal descent of testis was responsible by anti-Mullerian hormone. Can you see that? Anti-Mullerian hormone does your abdominal descent of testis, and your scrotal descent of testis is done by, can you see that? It is done by testosterone. Okay? Are you guys still with me? So, this is somewhat a boring topic, but knowing the embryology helps you a lot to understand many other things. Okay? So, Mullerian duct regresses in males. Mullerian duct regresses with one appendix, with one remnant known as appendix of testis. Remember this also, they can ask you appendix of testis. Okay, prostatic, it is also known as prostatic utricle. So your Mullerian duct gives you the remnant is appendix of testis, and the Wolffian duct's remnants is appendix of epididymis. Okay, so these are some extra information. At 6 weeks, both Mullerian ducts and Wolffian ducts are present in the embryo. Okay, at 6 weeks, the embryo, in the embryo, both your Mullerian duct and your Wolffian duct is present. At 9 weeks, one of these ducts disappear depending on the SRY gene, right? And at 10 weeks, internal genitalia are formed. Okay? Are you still with me? We are just ending the embryology. These are the main parts that are very important. Okay? So in absence of Y chromosome, like I already told you, SRY gene किसके ऊपर रहता है? Short arm of Y chromosome. So in the absence of Y chromosome, ovaries are formed. And since there is no Y chromosome, no SRY genes, there is no anti-Mullerian hormone. So this time, the Mullerian ducts, they grow, okay? The Mullerian ducts grows because there is no anti-Mullerian hormone to regress it, right? Anti-Mullerian hormone रहता तो वो ducts को खत्म कर देता था, पर अब ये है ही नहीं क्योंकि Y gene है ही नहीं, Y chromosome है ही नहीं, right? So that's why the Mullerian duct grows. And what does the Mullerian ducts give you? They give you 2 fallopian tubes, cervix, uterus, and upper 2/3 of vagina, right? And then there is no testosterone, so Wolffian duct does not develop, and that's why the remnants of Wolffian duct will be, since the Wolffian duct does not develop, it gives Gartner ducts, epifuron, parafuron, and epioufuron. Okay, so this was a previous year question. The remnants of your Wolffian duct are very important. Okay. Okay, so are you guys still with me? Your Gartner's duct, epioufuron, paraoufuron are your remnants of Wolffian duct. Okay, so let's go to the, so in the absence of Y chromosome, you don't have epioufuron is nothing but your there are 3 remnants, right? ये गलती से मैंने लिख दिया होगा, sorry. Okay, so basically absence of Y chromosomes, ovaries are formed, and since there is no anti-Mullerian hormone because you don't have SRY gene, that's why the Mullerian ducts grow. They give you the upper part of vagina, the uterus, the cervix, and the fallopian tubes. Okay, And since there is no anti-Mullerian hormone, there is no testosterone, the Wolffian duct regresses, right? And it gives its remnants, which are garter ducts, epifuron and paraoophoron. Okay? And since there is no testosterone, the natural tendency of the body, only when there is a presence of testosterone, then all the male secondary sexual characters develop, testis develops. So when this is not there, the fetus or the embryo's natural tendency is to grow like a female. ठीक है, क्योंकि इवन खुदा चाहता है कि हम औरतें पैदा हो, तो बेसिकली नेचुरल टेंडेंसी है फीमेल्स जैसा बनने की. ओके, yes, that is there. Ipu, they will never ask you which part gives you what. Okay, but what you need to remember is the remnants of Wolffian duct, where it belongs and all. Till now they haven't asked. I don't think they will ask anymore, because I think in OB-GYN clinical cases are more important now. Okay, so in absence of testosterone, the baby will develop as a female. Okay, gonads develop from genital ridge, very, very important. It can be asked as a anatomy question, embryological question. So your gonads are nothing but your ovary for females and your testis for males, right? And they develop from the genital ridge. Your uterus, fallopian tubes, your cervix and upper part of vagina, like I said, they develop from Mullerian ducts, which is mesodermal in origin. Okay, and lower 1/3, again, this has been discussed. Urogenital sinus gives you lower third of vagina. Okay, and it is endodermal in origin. Okay, so uterus is formed by 10 weeks, but the uterine cavity, right? Uterus is formed, but the embryo does not have a cavity yet. And the cavity is formed by 20 weeks. Okay? And then these are some embryological structures that you should know the origin of. So your genital tubercle gives clitoris in female and penis in males. Your genital swelling gives labia majora and scrotum in males, and your genital fold gives labia minora and penile urethra in males. So these clitoris is homologous to your penis, your labia majora is homologous to scrotum, and your labia minora is homologous to penile urethra. Okay, again one more time, just repeat it with me, that the genital tubercle, what do you get? In females you get clitoris, and the same homologous for that is your penis. Okay, from the genital swelling you get labia majora in females and you get scrotum in males, and from the genital fold you get labia minora, and in males you get penile urethra. Okay, so before we start menstrual cycle, there was this one more part. Okay, so this is actually in male, the prostate gland is homologous to the skin glands, which we have discussed in the image-based session, right? Your skin glands, please go through the image-based image-based session again. Your skin gland is homologous to prostate urethra. What does your skin gland do? It provides lubrication for your, it is also known as your paraurethral gland, right? And it provides lubrication to your urethral opening. And then you have your bulbourethral gland, which is homologous to Bartholin gland. Okay? So should we start menstrual cycle? Should we start menstrual cycle? Can you give me a yes? So I'm sorry, actually, I'm having a very tough time. Okay, so your menstrual cycle is very important. Why is it important? Because if you know the menstrual cycle, abnormalities related to, अगर आपको normal पता है तो उसका abnormal आप definitely you can tell me what is abnormal. Okay, so that's why your menstrual cycle is very, very important, right? So Where does the whole menstrual cycle start from? Your menstrual cycle always begins from the hypothalamus. What happens? It secretes GnRH, right? And that GnRH stimulates the anterior pituitary. Okay? Stimulates the anterior pituitary, which releases FSH. So your FSH and LH are released by the anterior pituitary. What does the posterior pituitary release? Can you tell me? Does anybody know what does the posterior pituitary release? This used to be a very important question long ago. Can you tell me what does the posterior pituitary releases? Very good, Dr. Pal. What else? Oxytocin and ADH. Oath breaker, good. LH is no, LH is done by LH and FSH are done by your anterior pituitary. There are two parts of the pituitary gland, right? There is anterior and posterior. Your LH, FSH, these kind of hormones are released by your anterior pituitary. The posterior pituitary gives you oxytocin and the ADH. Okay. So it's the hypothalamus secretes GnRH, and then which acts on anterior pituitary, okay, which releases FSH. Again, remember your anterior pituitary releases FSH and LH, which acts on the ovary, right? In the ovary, you have the ovarian granulosa cells, and ovarian granulosa cells secrete estradiol, which is nothing but E2, and inhibin B. Okay, can you tell me what is E1? E2 you already know, it is estradiol. What is E3 and E4? Can you tell me what is what? Can you tell me what is what? E1 is known as? Very good. It is known as estrone. What about E2? That's your estradiol. What about E3? Estriol. Very good. What about E4? What about E4? Very good. It is your estra. Very good. Estratetrol. Okay. So this is your E1, E2, E3, E4. This was also a question asked before. So you should know what E1 is, and E1 is produced by your androgens, right? Your androgens, they get aromatized, okay, and aromatization happens, and that's when E1 is formed, right? Very good, guys. So basically what happens is your ovarian granulosa cells, which is stimulated by the FSH, it produces estradiol and inhibin B. So what is the function of both of this? Estradiol causes proliferation of endometrial glands, okay, and that's very important. It causes proliferation of endometrial glands, and it gives negative feedback to LH. Okay, so it gives positive feedback to LH. Sorry, it gives positive feedback to LH, and that's why LH increases, right? So FSH gets released by the anterior pituitary. It acts on the ovarian granulosa cells. Ovarian granulosa cells produce estradiol, secrete estradiol and inhibin B. B is very important. And what do? They cause proliferation of endometrial gland. Yes, Ashwini, very good. Actions, what are the actions of LH? There is an LH surge which is caused by the sudden rise of LH. With sudden rise of LH, why has it happened? Because estradiol gave a positive feedback to LH, right? So this happens approximately 32 to 36 hours before ovulation. They usually don't ask this, but 30, just remember 36. 36 hours before ovulation, your LH surge begins. LH peak is nothing but the minimum LH required for ovulation. मतलब आपको इतना LH चाहिए ही ovulation के लिए. And what is that? Okay. So that is done 10 to 12 hours before ovulation, and minimum LH required for, which is very important, required for ovulation is 75 nanogram per ml. Okay. So your LH, it also acts on the Tikha cells, and Tikha cells secrete androgen, and this, like I said before, this undergoes aromatization by the enzyme aromatase, and it produces estrone. Okay, it produces estrone. So what have we learned? LH के actions क्या होंगे? There is an LH surge 36 hours before, and then there is an LH peak, which is the minimum LH required for your ovulation. And what is that minimum LH required? It is 75 nanogram per ml. And what else it does? It acts on Tikha cells, which produce androgens, which get converted to estrone by aromatization, right? And this occurs maximally, like somebody said before. It occurs in adipose tissue. Ashok Kumar, आप इंजीनियर होके भी ये देख रहे हो क्यों यार? आपकी पढ़ाई कम नहीं थी आपके लिए. Anyways, so yeah, LH surge, the minimum LH required, is 275 nanogram. And yeah, you're right, Sharat. बाबा रामदेव के बारे में बता रहा है यार. वो तो एक, मतलब क्या ही बोलूं, मैं गाली देती ना सीधा उसको अभी. तो LH acts on, it acts on Tikha cells, and then you get your androgen, which aromatizes to your estrone, but it also acts on granulosa cell. Okay, and granulosa cells secrete progesterone, which causes your mid-cycle FSH surge. Okay, so there is mid-cycle on 14th day, there is an FSH surge, which is caused by your progesterone. Okay, so are you guys with me? I know this is kind of boring, but I hope you guys are with me. Okay, so why do you need a mid-cycle FSH surge? Because it helps in the final maturation of follicle. So when the cycle starts, right, menstrual cycle, there are many follicles. Okay, there are many follicles, and then in between they all grow together. But then only one follicle starts growing and the others regresses. Okay, so what happens? This one follicle that grows 2 mm per day, and it is known as the dominant, leading, or captain follicle. Okay, I hope you can see this. And it keeps growing until it is, when it is 14 mm, it is known as dominant leading follicle. Okay, and all the other follicles regresses in this time. When one dominant follicle is made, बाकी के सब follicles they regress. Okay, and this is known as dominant leading or captain follicle. Once it gains a size of 18 to 22 mm, it ruptures. Okay, around at 20 mm it ruptures, and also one more thing, when once the follicle reaches 14 mm, both estradiol and inhibin B, which were, first, what were they doing? They were proliferating the glands, right? They start giving negative feedback to FSH, causing regression of remaining follicles. All right? Yes, Ashwini. Yes, at day of ovulation, it uh, it uh, it is 18 to 22. So ovulation, what happens once ovulation is done on day 14th, right? So let's go back to how it was. Your mid-cycle FSH surge, it helps in final maturation of follicle. And since how was the FSH surge caused? It was caused because LH act on granulosa cells, right? LH act on granulosa cell, and progesterone was secreted, which uh, stimulated the FSH. Okay, but what happens once the size is 14 of the follicle, then estradiol and inhibin B, they give negative feedback to FSH. Okay, so then FSH does not cause growth anymore, right? And that's why all the other follicles, they regress. Okay. So after ovulation, the ruptured follicle is called as corpus luteum. Okay, and it is yellow due to the carotene in it. जो carrots में रहता है वही carotene रहता है, उसकी वजह से it's yellow. So your after ovulation, your ruptured follicle is called corpus luteum, and corpus luteum is supported by LH, which is very important to remember, because अगर आपका LH गिर जाता है, then corpus luteum is not supported anymore, right? And corpus luteum, it produces certain things which are very important. Okay, so corpus luteum, it secretes 3 hormones. Like I said, it secretes 3 hormones in a non-pregnant female and 4 hormones in a pregnant female. Okay, so it secretes estradiol, it secretes progesterone, which is the main hormone secreted by your corpus luteum, and inhibin A. Ovarian granulosa cell gave you inhibin B, but here you get inhibin A, okay, by corpus luteum, and relaxin in pregnant females, so that you know the uterus relaxes. Okay, so basically you have to remember what LH, corpus luteum is supported by LH, very, very important. What does corpus luteum make? It makes the predominant hormone, which is your, what is it? Can you tell me what it is? It is your progesterone. Then you have your inhibin A, relaxin in pregnant female, and it also makes estradiol, right? So what are the actions of progesterone? So we are talking after ovulation, right? So the predominant hormone in the cycle, in the beginning of the cycle till day 14, till your ovulation, was your estrogen. Why? It was causing proliferation of all the glands. But in your second part of the cycle, which is after the day 14th, the predominant hormone is your progesterone. Okay, and that is because that is made by your corpus luteum, which is nothing but your ruptured follicle, right? So what happens? Your actions of progesterone. What are your actions of progesterone? They support endometrium. They cause vasodilation so that the endometrium gets increased blood supply, and they secrete glycogen and lipids in endometrium so that they provide nutrition to the fertilized ovum, if there is any. Okay? If ovum is fertilized, then the glycogen and the lipids, they provide nutrition. Okay, so they cause vasodilation, they cause support to the endometrium, and they also produce glycogen and lipid for the fertilized ovum. What is the activity of corpus luteum? It is max on day 8 post ovulation. So can you tell me what is the day 8 of post ovulation? Can you tell me? I know it's written, but very, very important. There are cases where, you know, and you should always remember that your other half of the cycle, right? Your progesteronic phase of the cycle is always fixed. So if I tell you that that a lady got her periods in 52 days, and when does ovulation happen in this lady? Can you tell me the date of the ovulation, if anybody is listening? Very good, Ashok. Max progesterone is on day 22. If a lady has a 52-day cycle, can you tell me when ovulation occurs in this female? Sharat, very good. Sahib, very good. So, what do? Your second phase of the cycle is always fixed, right? Second phase of the cycle is always fixed. Okay, so you just subtract 14 days from the 52 and you get 38 days. Okay, 38 days. Very important. It can be asked as a question in this exam also. It was asked before. So always remember that the second phase of the cycle is always fixed. Okay, and so your maximum activity happens on day 18, day 8 post ovulation. So your day ovulation is on 14th day, and 8th day after is nothing but 14 plus 8, which is your 22nd day of the cycle. So it is maximum, and since their maximum your corpus luteum activity is maximum, so it will definitely produce the predominant hormone that it produces is your progesterone. That's why the activity of progesterone will simultaneously be higher also, right? So if ovulation has occurred, progesterone should be at least more than or equal to 3 nanogram per milliliter. Okay. If ovulation has occurred, then progesterone will be at least more than or equal to 3 nanometer, and it will give negative feedback to LH. So if and then LH, if what happens, negative feedback to LH is given. LH supports your corpus luteum. So if LH is not there anymore, then it will not support your corpus luteum, and that's why it degenerates, and it is known as corpus albicans once it degenerates. And since corpus luteum has degenerated, the hormones that it secretes will not be present anymore, and the main hormone that it secreted was progesterone. And what were the functions of progesterone? It was supporting the endometrium, so it will not be able to support the endometrium. It was causing vasodilation so that more blood supply was supplied to uterus, but now that cannot happen anymore. And due to this, since the blood supply has stopped, there is myometrial contractions and endometrial paralysis. Due to this, there is apoptosis and release of PGF2 alpha, right? Blood supply of endometrium has decreased, and due to that you have apoptosis, and you also have release of PGF2 alpha, due to which you have myometrial contractions and endometrial peristalsis. So what happens? Your progesterone is not there anymore. It does not support your endometrium. Because there is decreased blood supply, because it was causing vasodilation before, since it's not there anymore, vasoconstriction happens, and that gives rise to your PGF2 alpha, which causes endometrial contraction, myometrial contraction, and endometrial peristalsis. That's why the uterus starts becoming, and that's why the female gets pain also at this point. And then there is also release of metalloproteinase enzyme, which causes ischemic necrosis of endometrium. Already the blood supply of endometrium has been reduced, and so due to this enzyme, there is ischemic necrosis as well. So due to all these things, endometrial shedding happens, okay? And that the blood, it gets, there is fibrinolysis, due to which arterial, mainly because apoptosis is there, right? So arterial blood comes from the uterus, and already you know the PGF2 alpha is contracting the uterus. That's why the blood is able to come out. Okay, So hormone responsible for LH surge is your estradiol. Very important points. So can you understand what happened all the while? Menstrual cycle कैसे शुरू होता है? It starts all the way from hypothalamus. Anterior pituitary gets stimulated. Anterior pituitary gives you FSH. FSH acts on your granulosa cell. Granulosa cell gives you your inhibin B and estradiol. In the first phase of the cycle, your estradiol क्या करता है? वो endometrial glands को proliferate करता है. Okay, so all these changes that happen in the first phase of the cycle, right? And then it gives positive feedback to LH. And then what does LH do? What does LH support? Then what corpus luteum makes, and then what progesterone does. All these are very, very important in your menstrual cycle. Okay, should we move ahead? Should we move ahead? Because you understood the menstrual cycle, I hope. So your minimum amount of estradiol required for LH surge is 200 picogram per ml. Okay, and it should be available for at least 48 hours. Continuously, your estradiol should be at least 200 picograms per ml. In the first half of the menstrual cycle, like I said, the endometrial glands get proliferated. That's why it's known as proliferative phase. And it is known as follicular phase and estrogenic phase, because FSH and your estrogen is the estradiol is the main hormone responsible in the first half of the cycle. Then your second half of the cycle is your secretory phase. Why secretory? Because progesterone is secreted, inhibin B is secreted, LH supports. That's why there is secretion of hormones, and it is known as your luteal phase, because very predominant hormone supporting the corpus luteum is your LH. And progesteronic phase, because progesterone is the hormone that is supporting your endometrium. It is the one which is causing vasodilation. It is the one that is giving glycogen and lipid for the fertilized ovum, if there is any, right? So this is very important. Okay, and the rate of follicular growth, like we said, it is 2 mm per day, and the size of the dominant follicle is 14 mm, and the size of the mature follicle is 20 mm. Okay, after 20 mm it ruptures. So we are done with menstrual cycle. Let's go ahead to puberty. So puberty is very important. Why? Because if you understand the normal things about puberty, then you're able to tell what is abnormal and what happens in abnormal puberty. There is primary amenorrhea, there is secondary amenorrhea. Okay, and how do you understand the things related to that? Only by understanding what is normal, right? So puberty is what happens? Breast development in puberty is dependent on estrogen in females. Very, very important. And pubic hair and axillary hair is caused by androgens. Okay, androgen causes the growth of your pubic hair and your axillary hair, while your breast development is dependent on estrogen in females. Precocious puberty is nothing but when the female, she gets thelarche. Thelarche is nothing but your breast budding at 8 years of age, or menarche by 10 years of age. Okay, so what treatment do you give in this? You give continuous GnRH to stop the growth. Okay, if you give continuous GnRH, then the puberty will stop for a while. Okay, so what happens? Precocious puberty, because the way GnRH is released from the hypothalamus is in a pulsatile manner. Okay, the normality, जिस तरीके से GnRH निकलता है hypothalamus से, वो एक पल्सेटाइल फैशन में निकलता है. पल्सेटाइल मतलब पहले थोड़ा निकलेगा, रुकेगा, फिर निकलेगा, तो इट गिव्स पल्सेस. ओके, But if you give it continuously, it will not be able to act on the anterior pituitary properly. So that's why the growth will stop. And that's what you want in precocious puberty, right? आपको growth नहीं चाहिए इसमें, क्योंकि ये बच्ची बहुत छोटी है अभी, 8-10 साल में she's getting breast budding, she's getting menarche, she's having a menstrual cycle. So you want to stop that. So the treatment that you give is your continuous GnRH. But in India, we don't give any treatment, okay? We just, we tell her कि it's okay, बड़ी हो गई तो. So delayed puberty is when there is absence of development of breast or absence of menstruation by 13 years or no menstruation by 15 years. So basically, if you have secondary sexual characters, then delayed puberty is you have secondary sexual characters, but you don't have menses till the age of 15 years. That is known as delayed puberty, or it is also known as a female not having secondary sexual characters also, like thelarche, and she also does not have a menses. So that is also known as delayed puberty, and the most common cause of this is constitutional delay. Okay, and what do you do here? You want the development to happen, so you give pulsatile GnRH. Okay, I hope you guys are still with me. We will go to amenorrhea now. Okay, very important topic. So there is primary amenorrhea and secondary amenorrhea, right? So your primary amenorrhea is caused by, what is your primary amenorrhea? When the female has never got her menses. She never had a menstrual cycle. Okay, that is known as your primary amenorrhea. See, the female has never experienced menstrual cycle. Most common cause of this is Turner syndrome. Okay, and the best investigation that we do for your amenorrhea is karyotyping. Why? Because there is a difference. Turner syndrome, the karyotype is 45XO, right? And then you have other syndromes also whose karyotype is different. Okay, so let's go to case 1. If we are talking about a female in this case, where the secondary sexual characters in the female is present, but she is not having her menses. So what happens? We have to check whether uterus is present or it is absent. So like if uterus is present, then the main cause of amenorrhea is your imperforate hymen. And what happens in this case? What happens in imperforate hymen or cryptomenorrhea? There is cyclic abdominal pain. ये female में कैसे symptoms, clinical features रहेंगे? She has cyclic abdominal pain. There can be, because there is blood coming every month and she has pain during that time. So what happens? This blood is not able to go out because she has an imperforate hymen. What is an imperforate hymen? That hymen is not it does not have a opening. Basically एक normal hymen में एक छोटी opening रहती है जिसके through the blood can go out. But in this hymen, the imperforated hymen, there is no opening. So when menses happen, the blood gets collected in the uterus. It keeps getting collected in the cervix, okay, and the vagina. So that female can present with on pelvic examination, right? When you do pelvic examination, she will have a bluish tensed hymen. Why? Because there is collection of blood behind the hymen, which is in your cervix, right? Cervix and vagina, in your cervix and vagina. So, but FSH and LH, again, your hormones are going to be normal in this case, and she might have hematocolpus, which is nothing but the blood in cervix, and she can have hematometria. Blood keeps collecting and it keeps going behind, right? So it goes from your vagina to your cervix to your uterus till it goes all the way to the fallopian tubes. And it can also, if the blood is so much more, then it can also continue to your peritoneum. Okay, so there are names for that. And so the most common cause of a young female having endometriosis is your cryptomenorrhea. Okay, because she will have retrograde menstruation, which can lead to endometriosis. Okay, why? Because your if the blood keeps going all the way to your peritoneum, right, it also collects tissue with it. So that's why it can cause endometriosis, right? So that you need to remember, this female has secondary sexual characters present. Okay, so uterus is present in her, and what is the problem? She has a imperforated hymen. What is the treatment? You do a cruciate incision on the hymen. Cruciate in the crisscross incision. Okay, you do cruciate incision so that the blood can go out. That's the treatment for imperforate hymen. If the uterus is absent, it can either be Mullerian agenesis, which we have talked about. This is a female with the karyotype 46XX. And can you tell me what is IMRKH? Yes, Ashwini, very good. Can you tell me what is IMRHK? So nobody's replying. But anyways, so Mullerian agenesis is nothing but when the ducts are not present at all, right, in this female. And that's why what happens, she doesn't have her upper part of the vagina, she doesn't have uterus, she doesn't have fallopian tubes, but the lower part of the vagina is present. Why? Because it is formed by the urogenital sinus, and your ovaries are normal because ovaries are formed by your genital ridge. See, this is why embryology matters, right? Because you already learned that in embryology, so you can understand why she has ovaries. Why? And ovaries will form estradiol, due to which she will have secondary sexual characters, right? So the presence of secondary sexual characters are present in this female. Why? Because her ovaries are normal, right? And they will produce estradiol, which causes secondary sexual characters in females. And she will have a distal vagina will be present. Why? Because it is formed by the urogenital sinus. FSH and LH will be normal. Estrogen will be normal because estrogen is normal. But the problem is what? She does not have the lower part of the, she does not have the uterus, right? So there are two cases in which the uterus is absent but the secondary sexual characters are present. One is your Mullerian agenesis, the other is your, what is AIS? Can you tell me? Can you tell me what is AIS? Can you tell me what is AIS? Can you tell me what is AIS? It is nothing but your androgen insensitivity syndrome, right? What happens in this case? You have androgens, but the receptors are not working, receptors are insensitive. Okay, so that's why this person is actually a male, but since the receptors are not working, the androgens get converted to estrone, and that's why there is breast development. There is inguinal hernia. Why? Can you tell me why there is inguinal hernia? Because there is abdominal descent of testis, right? So it can present as inguinal hernia. So this person has testis, but it's in her abdomen. It has not descended all the way down. And levels of FSH and LH, since testis produces inhibin and testosterone. Inhibin gives a negative feedback to FSH, so FSH decreases in this case. You don't have to remember this. All you need to remember is karyotyping is very important. Why? Because androgen insensitivity syndrome's karyotype is what? 46XY, and the Mullerian agenesis karyotype is 46XX. Okay, this patient will have inguinal hernia, might have inguinal hernia due to abdominal descent of testis. And what happens in this case? What is the treatment for both of them? They cannot produce kids. Okay, you can give them what do? You do vaginoplasty just before or after marriage. Plus, in this case, in androgen insensitivity syndrome, you also have to do orchidectomy, right? Orchidectomy should be done. At puberty, at around 14 to 5 years, orchidectomy should be done. Why? Because it can cause malignancy and let this male live a female life, because all the while it has been living, she has been living like a female. So you tell them to get vaginoplasty whenever they are going to get married. And yeah, you can do surrogacy or surrogacy for the you can try IVF, but to be honest, IVF does. There are very few cases where IVF has worked on these kind of females. Okay, because she doesn't even have a uterus, right? So she will have to do IVF, where she'll take her. We are talking about Mullerian agenesis, right? Because ovaries are present. So you can take the eggs by doing IVF, and then you have to use that eggs to transfer to another female, right? Because this female does not have uterus, so she cannot get pregnant, but she can use her eggs to get somebody else pregnant on her behalf, which is known as surrogacy. But in India, you're not allowed, and in America, it's allowed. But again, there's a very big ethical debate, right, on it. Uterus is absent, so surrogacy can be done only in this case, right, in Mullerian agenesis, because surrogacy cannot be done in androgen insensitivity syndrome, because there are no presence of ovaries, right? So in this case, you give you do orchidectomy, and since there is no presence of ovaries, you also give estrogen, right? Because estrogen will provide secondary sexual characters, right? Yes, that's the thing. Okay, so let's go to what have we learned about the first case. The first case is when the female has secondary sexual characters. You can get three cases here. Either the female has secondary sexual characters and her uterus is present. If the uterus is present, the female has cryptomenorrhea or an imperforate hymen. Okay, and what do? What is the management? You do a crisscross incision, yeah, a cruciate incision, right? And if the uterus is absent, then you can have two cases where you do Mullerian agenesis, where you can get Mullerian agenesis or androgen insensitivity syndrome. In Mullerian agenesis, what happens? The Mullerian ducts are not present. So your upper part of the vagina, your uterus, your fallopian tubes, they're all absent. Your cervix is absent, but the lower part of vagina is formed by your urogenital sinus. That's why it's present, and the ovaries are normal because ovaries are formed by the genital ridge. So that's why this female has secondary sexual characters, because your ovaries will give out estrogen, and estrogen is responsible for the secondary sexual characters in females, right? In androgen sensitivity, what happens? Breast development takes place because the androgens get converted into estrone. And again, estrone is responsible for your secondary sexual characters in female. And the patient might have an inguinal hernia because of the abdominal descent of testis, and the testis produces inhibin and testosterone. So your LH gets increased because there is no negative feedback to the LH because testosterone is so high in the body, right? So can you tell me, there are two questions about this. What is the best way to differentiate? What is the best way to differentiate? What is the best investigation of choice to differentiate between AIS versus your Mullerian agenesis? Can you tell me what is the best investigation of choice? Can you tell me what is the best investigation of choice? Yeah, very good, Anuru. It is your karyotyping. But what about physical examination? On physical examination, how can you differentiate? On physical examination, how can you differentiate between the two? Can you tell me on physical examination, what is the one finding that is very, very important? What about on this thing, on physical examination? Yeah, Anurup, very good. So your axillary and pubic hair will be missing in which case? Will be missing in which case? Can you tell me in which case will the axillary and pubic hair will be missing? In androgen insensitivity syndrome, right? It will be missing in androgen insensitivity syndrome. Why? Because your androgen are insensitive, the receptors are insensitive, so they will not be acted upon. Your androgen gives the secondary, this thing, right? The androgen gives your pubic hair and your axillary hair, right? But what if they're not able to work because of the receptor insensitivity? That's why you don't have pubic hair and you don't have axillary hair in AIS. Okay, so this is a picture of hymen. Okay, just hymen. So what can you see? This is a normal hymen. Can you see a hole in the hymen? Okay, this is a normal hymen. In B, this is actually your imperforate hymen. Can you see there is no hole in this? In microperforate hymen, there is just one small hole. So this is known as microperforate hymen. And there is also cribriform hymen which has small holes on it. So this is known as cribriform. Usually this hymen and septate hymen, you don't find these out in patients because the blood comes and it goes out easily. But the main problem comes with this hymen, right? Your imperforate hymen. Okay. So these were pictures of your hymen. Then you can also see, can you see this image? This is your imperforate hymen. If you can see, this is actually where your urethra is. Your urethra is here. And this part was supposed to be opened up. Okay, there should have been a hole here, but there is no hole. Okay, that's why. Can you see how it's bulging? So that's why that's the picture of an imperforate hymen. Now let's go to the second case. If secondary, we were talking about secondary sexual characters being present, but what if secondary sexual characters are absent this time? Let's take a female जिसके secondary sexual characters absent है. What do you mean by absence of secondary sexual character? She will not have breast development. She will not have what do you say? She will not have hirsutism. She will not have all these things, right? So that can either be a patient who is short or it can be a normal patient. So a patient who is short, can you tell me what syndrome is? Yeah, Pradyut, very good. So what syndrome is there if the patient is short? it has been already written here. So if the patient is short, she will have Turner syndrome. Why? Because Turner syndrome is, yeah, short stature, and she has streaky ovaries, due to which, since she has streaky ovaries, there will be no presence of estrogen. Estrogen will be very less or almost absent in this female, due to which she will have no secondary sexual characters. Okay, because of this streaky ovaries give your estrogen, right? But if they are not working properly, then how can they give you estrogen? And that's why you don't have secondary sexual characters. So in a Turner syndrome female, she also has other she also has other symptoms, right? Like she has webbed neck, and she has white space nipples, and her fourth metatarsal or metacarpal is short. All these things you need to learn about. You make sure that you, and she also has cardiac malformations, right? Congenital malformations. And bicuspid valve is the most common cardiac malformation. So all these are very important in Turner syndrome. I have discussed this, that's why I have not written it here. If the patient's height is normal but she does not have secondary sexual characters, then the patient can either have pure gonadal dysgenesis, and in pure gonadal dysgenesis, the karyotype is always going to be, like, there is a difference of karyotype. Again, there are two syndromes in pure gonadal dysgenesis. So we are talking about a female who does not have secondary sexual characters, and she is of normal height. If the height is not normal, it is Turner syndrome. If the height is normal, then it can be pure gonadal dysgenesis. और pure gonadal dysgenesis में क्या है? You have Sweber syndrome, or you have pure gonadal dysgenesis. And again, pure gonadal dysgenesis has streaky ovaries. So streaky ovaries will again not give you estrogen, due to which again you will not have secondary sexual characters. Okay, so Sweber syndrome is actually a defect in SRY. So Sweber syndrome, in pure gonadal dysgenesis, the karyotype is 46XX, but in Sweber syndrome, the karyotype is 46XY. So this is actually a male, but the problem is in the Y chromosome, right? There is a defect in SRY gene. Okay, due to which due to defective SRY gene, and you know SRY gene gives you testosterone and anti-Mullerian hormone. So if they are not able to give you testosterone and anti-Mullerian hormone, then absence of testosterone will not let you develop the Wolffian duct. So you will not have male characteristics. The male will grow like female because there is no Wolffian duct, and there is anti-Mullerian hormone, right? There is absence of anti-Mullerian hormone, so the Mullerian duct grows and it will give you uterus, it will give you fallopian tube, and it will give you the upper part of vagina and the cervix, right? Are you with me? Are you understanding? Because this is a very important part. So it will give you female internal genital organs. What about if the patient's height is normal? There is another problem that can happen, which is known as Kallmann syndrome. Can you tell me what is Kallmann syndrome? And this patient, actually, this female who has Kallmann syndrome actually comes with anosmia. That means she cannot smell. So can you tell me about Kallmann syndrome? Kallmann syndrome. Can you tell me what is Kallmann syndrome? Yes, there is a hypothalamic failure, okay, in Kallmann syndrome. Okay, Yeah, so there is decrease GnRH, due to which the anterior pituitary does not get stimulated, due to which there is decrease LH and FSH. Okay, so this is known as Kalman syndrome. So in all three, what do you do? In all three, estradiol is decreased. Why? Estradiol is decreased because ovaries, either there are streaky ovaries, as you can see. Like I just want to show you. In Swaver syndrome, ovaries are decreased because there are no ovaries. So they do not produce estradiol. And then in pure gonadal dysgenesis, there is streaky ovaries. So again, they do not produce estradiol. And in your Kalman syndrome, the GnRH is decreased. That's why there is no stimulation to the anterior pituitary, and that's why the granular, you don't have increase in E2. That's why in all three, E2 decreases and LH and AH, they increase. Okay, so uterus is present but it is hypoplastic, and external genitalia is of the female. Okay, very good, Anil, very good. So what happens, how do you diagnose all these three? You do karyotyping. Why? Because in Turner syndrome, the karyotype is 45XO. In Swaver's, it is 46XY. And in pure gonadal dysgenesis, it is 46XX. That's why karyotype is very important. The teacher, Turner syndrome, she's shorter, but the rest two are, they are of normal height. But how do you differentiate? Karyotype is 46XY for Swaver, and for pure gonadal dysgenesis, it is 46XX. Okay, and that's the thing. Treatment for Turner syndrome is you give estrogen plus progesterone till the age of menopause, because she doesn't have estrogen, and you cannot give estrogen alone. It is volatile to do that. She will have malignancies later. She can get endometrial cancer. That's why you should always give estrogen and progesterone together. Okay, so Swaver syndrome, again, since Swaver syndrome is actually a male, there is presence of testes, so you have to do an orchidectomy. Plus, you also should give estrogen plus progesterone so that secondary sexual characters develop. And even in Kalman syndrome, what happens? There is decreased GnRH. That's why you give pulsatile GnRH. Okay? Very good, Pradyut. So, that's the thing about primary amenorrhea. And let's go to secondary amenorrhea. Then we'll do a few questions and then we'll take a break. Okay? So, secondary amenorrhea is absence of menstruation in 3 consecutive months in a female with regular cycles, or 6 months with irregular cycles. So if a female has regular cycles and she already had menses, but it stopped for 3 months, then we call it secondary amenorrhea. Or if the female is she has irregular cycles and it has stopped for 6 months, then we call it secondary amenorrhea. Okay, so the most common cause of secondary amenorrhea is pregnancy. Okay, but the rest, right? I'll tell you the causes. So the causes of secondary amenorrhea is, it can be due to endometrial TB, which is very, very important. Endometrial TB is very important for your exam, and that is known as Asherman syndrome. What happens? There is inside the, if you can see, this is the uterus. Okay, this is the uterus, and in the uterus cavity there are fibrous bands which cause adhesions and synechia, right? Which inhibit, due to which your endometrium cannot grow. Okay, so they inhibit the proliferation of the endometrium because of the fibrous bands in the uterine cavity, right? And that's why you have a thin endometrium, and that's why you have hypoamenorrhea in the beginning. Like the female will get just little bit of menses, and then it completely stops at one point. So hypoamenorrhea is less menses, amount of blood should be actually more than 20 and equal to more than 20 and less than more than 20 to 80 is the normal, right? I think this is the normal. So if it is less than that, it is known as hypomenorrhea, right? And the normal duration of the menses is 2 to 7. So if it is less than 2, that means you have hypomenorrhea, right? So most common cause is Asherman syndrome, which is genital TB. And what do you do in this management of Asherman syndrome? There are fibrous bands, so you should do fibrinolysis. So you have to do hysteroscopic adhesiolysis. What do you do? Hysteroscopic. You put a hysteroscope and then you cut out all the bands, okay? And then you insert a balloon catheter in the, after you do lysis, like you cut out all the bands, then you insert a balloon catheter or IUCD in endometrial cavity, okay? And then you give the female estrogen and progesterone so that she can start getting periods, okay? Then in the other cause of your secondary amenorrhea and the most common cause after pregnancy is your abnormal cause, the most common abnormal cause. Pregnancy is your normal physiological cause, right? So the most common cause of your secondary amenorrhea is your PCOD, okay? And at pituitary level, in the sense, at your pituitary level, we talked about your ovarian level, we talked about your endometrial level. At endometrial level, it is your Asherman syndrome. At your ovarian level, it is your PCOD, and at your pituitary level, it is your pituitary tumor, which is pituitary adenomas, right? Known as prolactinoma. So you also have Sheehan syndrome, which is nothing but your postpartum necrosis of the anterior pituitary, okay? Postpartum necrosis of your anterior pituitary due to severe postpartum hemorrhage, okay? So this lady has hemorrhage due to which the blood supply to the anterior pituitary decreases, and that's why there is a anterior pituitary necrosis, okay? That's why your LH, again LH and FSH, the whole lining, right, from hypothalamus to LH, FSH to anterior pituitary to this, that will completely get disrupted, and that's why you in Sheehan syndrome, the FSH and LH are completely decreased because the anterior pituitary is necrosed. It will not be able to produce both of this, right? And your TSH decreases because this female will, due to decrease in TSH, which is also produced by your anterior pituitary, she will have hypothyroidism, and she will get cold intolerance and constipation. She also has a decrease in ACTH. All these are produced by your anterior pituitary. So there is diminishing of axillary hair and pubic hair, and also decrease in MSH, which is your melanin stimulating hormone, right? So it will cause vitiligo like patches, okay? So the earliest failure that happens due to the anterior pituitary necrosis, Sheehan syndrome, is she already has a baby, because this happened after postpartum hemorrhage. So when she's trying to feed her baby will not be able to lactate, okay? She will not have enough milk left because there is decrease in prolactin, right? So lactation will not occur. And management again is you have to give all the hormones orally, okay? Orally or through from outside, because the body cannot produce it anymore, okay? So at hypothalamic level, which is your which produces GnRH, stress and excessive weight loss can cause secondary amenorrhea. Okay, so this is not really important, but the rest, Sheehan syndrome, which is at your pituitary level, the pituitary adenomas, the PCOD, and your at endometrium, you have your Asherman syndrome. These are very, very important causes of secondary amenorrhea. Okay, so let's do 5 questions. I just want you to answer this. A 7-year-old female has not attained menarche, presents with acute abdomen. She also complains of having pain in her lower abdomen for few days, usually at the same time every month. This condition, known as cryptomenorrhea, may be seen in which of the following conditions? So can you reply to me? Very good, guys. So, see, these kind of clinical questions can be given to you. She's a 17-year-old female. She has not attained menarche. Presence with acute abdomen. That means that she must have had periods. She also complains of having pain in her lower abdomen for few days, usually at the same time every month. So she must be having periods, but because of the imperforate hymen or cryptomenorrhea, she is not able to get the menses out of her body, and that's why she started having acute abdomen, right? So this condition is seen in imperforate hymen. Okay, all the other Asherman syndrome, testicular feminization, uterine agenesis, this cannot be causes, right? So a 16-year-old female has not started having her menstrual cycle. Her secondary sexual characteristics appear normal, as does external examination of her genitalia. She's given an intramuscular injection of progesterone, and 5 days later, she has her first period. The mechanism responsible for the delay in menses. बोल दीजिए जरा. Read the question carefully. Okay. She's given an intramuscular injection of progesterone, and 5 days later, she has her first period. The mechanism responsible. Okay. Any answers? Guys, think and give me an answer. Hypopituitarism. Okay, Chavez, Parniti, very, very good. Anurup, very good. She has a normal constitutional delay. Why? This line is very important. She was given progesterone for 5 days. Later, she was given progesterone, and 5 days later, she has her first period. Okay, she has her first period is very important, because in any other category, in any other symptom, she should not be having her periods even after giving progesterone. Okay, so if she was hypoestro, she doesn't have estrogen, how will giving progesterone help? Okay, how will it help? So it cannot be A. Hypopituitarism, even if I give progesterone, you still need estrogen, right? You cannot have a period right after that. So an end organ abnormality, how does it even matter? Even why is progesterone? The main thing here is if you give progesterone, 5 days later she has her periods. That, yeah, you need to see that she has normal secondary sexual characters, and she has, what does she have? She was given progesterone, and 5 days later she had normal periods. That's why it is a normal constitutional delay. Okay, the next question. A 36-year-old P1L1 woman with previous regular menstrual cycle presents with amenorrhea of 6 months. Her pregnancy test is negative. Which of the following may be a cause? MRKH syndrome, Sheehan syndrome, Kallman syndrome, Turner syndrome. Come on, reply everybody. Guys, can I get a reply? Can I get a reply? Yeah, she has secondary amenorrhea, right? Very good. So why should B be your answer here? See, she has secondary amenorrhea. She already has, like, your biggest clue should be she has secondary amenorrhea. Okay. Is MRKH syndrome primary or secondary? Can you tell me, is it primary or secondary? This is primary. Kallman syndrome, you know that it was due to hypothalamic failure, right? GnRH was reduced in this. Okay, and you give pulsatile. That's why she had primary amenorrhea, right? And in Turner syndrome, again she has primary amenorrhea. So the option that you can see here is only the one cause, and she was told that she was pregnant. She was pregnant, and she gave pregnant after her pregnancy only she got this thing, right? She was pregnant once, so right after that, like 6 months, she didn't have period. So this must be Sheehan syndrome, which is caused due to postpartum hemorrhage. Okay, the anterior necrosis. Yes, that's the thing. So your mind should be working in this direction. Okay, कि पहले तुम देख लो ये प्राइमरी है, ये प्राइमरी है, ये प्राइमरी है, and this female is having secondary amenorrhea because she was pregnant once. That should be your biggest clue. So you don't need to go much into thought with this. Okay, so the next question is, an 18-year-old girl presents with amenorrhea, milk discharge from bilateral breast, weight loss. Most probable diagnosis is pituitary tumor, anorexia nervosa, hypothyroidism, hypothalamic cause. I want to see who gives me the right answer in this. And this is an easy question. You should not go wrong with this. Look at the symptoms that she's having. Okay? Yeah, good everybody. So that's the thing. What can you see in this? Why pituitary tumor? This must be, what is it? What is the diagnosis? Pituitary adenoma, right? Why? Because she has amenorrhea, because there is decreased LH and FSH here. Milk discharge from bilateral, this is pituitary adenoma, right? So she has a pituitary tumor That's why prolactin has been increased in this case. Prolactin increases, due to which he has bilateral milk discharge. Weight loss, because in tumor, in cancer, you always get weight loss, right? That's why this is a pituitary tumor. And in hypothyroidism, like Pradyut said, you get weight gain. Okay, that's why you should not have, most likely you get weight gain in hypothyroidism, right? And anorexia, you get weight loss, but why will you get milk discharge in this? So the best case scenario, the best answer should be your pituitary tumor, right? The pituitary tumor, the milk discharge itself should have given you away. Okay. So let's go to the fifth question. 17-year-old presents with primary amenorrhea. I'm sorry for the spelling. Amenorrhea. On examination, there is absent breast development. However, vagina is normal. USG reveals a hypoplastic uterus and bilateral ovaries are not visualized. What is the diagnosis? What is the diagnosis? Answer. Okay, great. I see most of you answering the right answer. You have to think about this. This female presents with primary amenorrhea. Okay. On examination, there is absent breast development. In Mullerian agenesis, Swaber syndrome, and in these three, you have seen, right? Where is this? Wait. You have seen, right? Mullerian agenesis, you have secondary sexual characters are present, right? So this should already be out of the options, right? Mullerian agenesis should not be your question, should not be your answer. Why? Because she has breast development. So you have to choose only between Turner and Swaber. And in this case, Turner should be your answer because ovaries are not visualized. Okay, most common cause of primary amenorrhea is again your Turner syndrome, right? So if you don't get any other answer, you mark it as Turner syndrome, okay? And ovaries are not visualized because they're streaked. That is your main clue here, that it is Turner. Okay, you have streaky ovaries. That's why they are not visualized. And of course, the uterus is hypoplastic in this case. Okay. So let's take a short break of 10-15 minutes. Okay, we'll start again by, what is it? 10. We'll start by 6:50. Okay. Let's take a short break. We will start by 6:50. Okay. I'll just message in the group when we will be starting. All right. Okay, so let's start. Okay, so we were talking about the next thing we need to discuss, which is again very important, is your congenital malformations of the uterus. So basically, in congenital malformations of your uterus, in 7 to 8 weeks of intrauterine life, right, when the embryo is in the uterine life, two Mullerian ducts develop in the intrauterine life. Two Mullerian ducts develop, and the direction in which they develop is from above, from below to up, right? In above below fashion, right? Basically, they I'll show you a picture of how they develop. I think I need to. So, Mullerian ducts, right? So, they develop in the above below fashion, right? Like, look at this. So, they develop in the above below fashion, and at 12 weeks, right, the Mullerian ducts fuse with each other. Okay, fusion occurs at 12 weeks. Fusion occurs, and this is when they and the direction in which they fuse is below upward. Okay, below upward, and that is very, very important. So the fusion begins in below upward fashion, and at 20 weeks, right, inner walls of the fusion will give you a septate, and the septate will disappear. Okay, so at 20 weeks, the septate, when it's made completely, it disappears. Okay, the septate disappears. So you know that the urogenital sinus forms the lower one-third of vagina. Now the main thing is you have to remember two Mullerian ducts are formed, and they fuse together at what times they fuse, you remember, and the fusion occurs from below upward direction. Once the fusion occurs, these the fusion resolves, like the septa is formed and it resolves, and that's when you get the two fallopian tubes, the uterus, the cervix, and the upper two-third of vagina. Okay, I've already discussed this in the image-based session, right? So make sure that you go through those images, because that was already, like, the images of this part was already discussed there. So make sure you go through that image based session. So the abnormalities, can you tell me, if Mullerian ducts don't fuse at all, what happens? What abnormality happens? If Mullerian ducts do not fuse at all, can you tell me what happens? If they don't fuse at all, what happens? Very good, Alu Amin. It is uterine didelphys. You get two uterus. Right? You get two uterus, which is 50% of a normal uterus, right? If Mullerian ducts fuse but their inner walls persist even after 20 weeks of intrauterine life, what do we get? Can you tell me what do we get? What do we get? Can you tell me what do we get? Yes, very good start, very good Pradyut, Alu Amin. You get, uh, you get a septate uterus. And what if the Mullerian ducts fuse but their inner walls disappear partially? Okay, but the fusion occurs, but the resolving of the fusion, right? The resolving of the septa happens only partially. So what is it then? Yes, very good. It is subseptate uterus. What if there is one more, right? What if fusion occurs partially? What is that you fusion occurs partially? What is that uterus known as? If the fusion occurs only partially? If the fusion of the Mullerian ducts occur partially, what is that known as? Can you tell me? That would be no. See, uniconnuate uterus is different, right? Very good, Devashish. Devashish, it is biconnuate uterus. Yeah, heart-shaped uterus also. Heart-shaped, yeah. Okay. So that is your biconnuate uterus. Okay. And septate uterus is for this. Like, let me change the color of this. I'm sorry. Ah, okay. So septate is for this, right? Septate is for this. And then if only one Mullerian duct develops, what is that known as? Can you tell me what is that known as? If only one Mullerian duct develops. One Mullerian duct develops, what is that known as? Now that is your uniconnuate or banana shaped uterus, right? If dome of uterus doesn't develop, what is that known as? Can you tell me? That is known as your arcuate uterus, right? If the dome does not develop, the fundus part has to develop, right? If that does not develop, then it is known as arcuate uterus, dome of the uterus. Okay, most common congenital malformations of uterus is actually your septate. Okay, yeah, Pradyut flat topped, septate. And your most common complication of congenital malformation, because septate is the most common congenital malformation. It is actually your, what do you say? It is actually your abortions, the most common complication. Okay, of congenital malformations. So this is what you need to remember about this. Best investigation of choice, can you tell what is it? What is the best investigation of choice? Best investigation of choice is actually laparoscopy plus hysteroscopy. Okay. Why do you do this? Like I have already mentioned this in my image-based session. You do laparoscopy so that you can see the uterus from outside, uh, from outside, and from inside you do a hysteroscopy. Okay, most commonly investigation used is your transvaginal ultrasound, right? Ultrasound is the most common investigation used. And management, what is the management for this? Management is done if septate uterus is causing abortion, right? More than 3 abortions. Then for septate, yeah, best is MRI. Yeah. Best is this, best investigation is this, of course, but MRI is the second best investigation. Okay, best is laparoscopy plus hysteroscopy. Okay, so your management for septate uterus, if you have abortions, then what is the management? You do surgical. Can you tell me what is the management? You do surgical, hysteroscopic resection of the septa, right? You remove the septa. Okay, so you do resection of the septa. Okay. Yes, you do surgical hysteroscopic resection of, and for bicornuate, can you tell me what is the investigation? Or what do? You do metroplasty, okay? Metroplasty for bicornuate is done, right? Yeah, very good, Jamod. Very good. So let's go to polycystic ovarian syndrome. Again, a very important syndrome, but we will go through everything about polycystic ovarian syndrome because very important topic, and we have been telling this again and again. So it is also known as. Can you tell me what is it also known as? Can you tell me what is it also known as? It is also known as Stephen Levanthal syndrome, right? Very good, guys. Like, this is the best thing about teaching you people. Yes, you already know so many things that, I wish I knew when I was studying. Okay, so that's the best thing about teaching you guys. Just give me 1 second. Somebody is texting me. Okay, so it is also known as Steen Leventhal syndrome. What is the most common age in this? Most common age that you get PCOD is your reproductive age. Okay. What is the pathophysiology in PCOD? You have insulin resistance, right? Basically, what happens is there is insulin resistance, and that can later lead to diabetes if the PCOD is not controlled. Like the uh, main pathophysiology with your PCOD is your insulin resistance. Okay, and what are the symptoms that you get? You get hirsutism. You get, what else do you get? Can you tell me? The female becomes obese, right? What else? She becomes obese, right? And what else? She has acne. Okay. She has menstrual cycle disturbances. Yes, acanthosis nigricans, menstrual cycle disturbances. These are all the clinical features that you see, no? And she also has what do you call it? She has acanthosis nigricans. Right? So what is the diagnostic criteria? Again, we have done this so many times. I think you should go and see the image-based session because I've done this in another question also. Your Rotterdam's criteria is the one, the diagnostic criteria for PCOD. So what is Rotterdam's criteria? There should be at least, there are three criteria and at least two should be true. There should be menstrual cycle disturbances. There should be biochemical or clinical evidence of androgen, hyperandrogenism. Okay, and there should be On the USG, you should get, on ultrasound, you should get at least 9 to 12 um, unruptured follicles. Okay, of the size 1 to 9 mm. 2 to 9 mm, I guess. Please check this. I don't remember this exactly. So 2 to 9 mm, and or at least more than or equal to 10 cc of fluid and ovary. Okay. So this is your this is your diagnostic criteria. What is the management? Management, the best management that you do, that the most basic management that you're supposed to do is you're supposed to tell her to have lifestyle changes. Okay. So lifestyle changes, that means lose weight. Okay, you tell her to lose weight. She's supposed to lose weight so that things get normal. But if she has infertility, and you want to give her a drug, then the drug of choice for that is letrozole. If she doesn't get periods, then for her insulin resistance, her drug of choice is metformin. You start metformin after 3 months. First, you try to get her to lose weight by herself. If she's not able to do that, then you start giving her metformin after 3 to, yeah, good. The first thing you tell her to do is have weight loss, right? So the next topic, this was about shortly about, and she also has necklace appearance, right? On USG, she has necklace appearance. Please go through the image-based sessions. I've taken this already there, like very in detail. So these are things that you need to know about PCOD. Okay, vaginitis, again, it is infection that we are dealing with, and the main infections that we should know about is your bacterial vaginosis, your trichomonas, and candidiasis. So I have made a table of them. And the thing that you can do is, first we'll talk about the organism. In bacterial vaginosis, actually the normal bacterial vaginal flora, right, which is Dodeline bacilli, gets converted to Gardnerella mobilinens. Okay, there are others also that it can get converted to. In Trichomonas, the organism is always going to be your flagellated protozoa. And they keep moving, and movement is very important in Trichomonas, and it is known as Trichomonas vaginalis, right? And the organism for candidiasis, you have Candida albicans, right? So in the most common bacterial vaginitis is actually, the most common vaginitis is your bacterial vaginosis. Again, remember that it is not it does not have inflammation, because there is only a change in the vaginal flora, and that's why there is no inflammation in this condition. Most common is your bacterial vaginosis. Then we need to know if it can be sexually transmitted. So bacterial vaginosis cannot be sexually transmitted. That's why you don't give the treatment to the partner. But trichomonas can be sexually transmitted 100%. But candidal vaginosis usually is not transferred, but it can be. Okay, so we give treatment to the male only if the male presents with symptoms. In trichomonas, you give treatment to the patient 100 and the partner, the male partner, for 100%. Okay. Then symptoms in the bacterial vaginosis, the symptom that you can see is that the symptoms and the clinical features that you see is that it is a dirty, white, foul-smelling discharge. there is no itching. Again, there is no inflammation. That's why there is no itching. There is no pruritus. Again, because of the no inflammation thing. Okay. And the discharge in trichomonas is yellowish green discharge. You have to remember that there is intense pruritus in this case, and also pain while urination, which is known as dysuria. Also, the vagina is completely inflamed. So it is also known as a strawberry vagina, right? Angry looking vagina or strawberry vagina, right? Yeah, pearl of, yeah, okay. So basically, in this, the symptoms and the clinical features in candidiasis, the discharge is cottage cheese like curdy white discharge, and there is again intense itching in this thing and splash dysuria. Suddenly, the pain while urinating starts. Okay, so this happens in candidiasis. Again, very important when differentiating. But during my image-based session, I realized that you're very good at these three. Everybody knew about that. So the pH of the discharge, you should remember that this is the pH in which candidiasis survives is an acidic pH. That's why in pregnant female, since they have an acidic pH, the most common kind of vaginitis is candidiasis. Okay, in pregnant female, the pH of the vagina lowers down. That's why the most common cause of vaginitis is candidiasis. Okay, so then we have a pH of the discharge. Again, it is, you don't need to remember this. The main thing that you need to remember about the pH is about the candidas albicans. Okay. Then investigation of choice for all three, the investigation of choice is saline microscopy. What will you see on saline microscopy in bacterial vaginosis? There are vaginal epithelial cells to which bacteria adheres. What are these cells known as? Can you tell me what are these cells known as? Can you tell me what are these cells known as? Can you tell me what these cells are known as? Clue cells. Very good. They are known as your clue cells, right? Your clue cells. Okay. And in saline microscopy in trichomonas, you will be able to see motility because it's a flagellated protozoa, right? Or candidiasis mein, you will be able to see hyphae or pseudo hyphae because again, it is a fungus. So gold standard for bacterial vaginosis is you do gram staining, and in trichomonas you do culture, and that's diamond media. And in your candidiasis, again you do culture and you use Seborrhei's media. Okay. In gram staining, you will be seeing Nugent score where you do gram staining, then you look at the bacteria, the number of Gardnerella, and it should be more than 7 will tell you that bacterial vaginosis is positive, is present. Okay. Treatment of male, you do not do it in bacterial vaginosis. You will do it in trichomonas. And if the male comes with symptoms, then you do it in candidiasis. Okay. Amsel's criteria, this is for bacterial vaginosis. Again, any three, this is for diagnosing bacterial vaginosis. Any three of them should be positive. So there should be a dirty, white, foul-smelling discharge coating the vagina. That is your first criteria. And the patient's pH should be more than 4.5. Clue cells should be around 20% of the slide. And if you add 10% of KOOH to the discharge, then you should get a fish-like odor. And this is known as your whiff test. Okay? This is known as your whiff test. So that is about your vaginitis, right? Now let's go to the next topic, which is actually your um, PID, pelvic inflammatory disease. So can you tell me, AMSEL's criteria is actually for your bacterial vaginosis. Don't follow any other books. AMSEL's criteria is for your bacterial vaginosis. So PID, what is your PID? What is your PID? PID is actually pelvic inflammatory disease where the whole whole pelvis gets this thing, right? It gets completely what happens to the pelvis? It gets inflamed. Okay, that's why it's known as pelvic inflammatory disease, right? So what is pelvic inflammatory disease? It is inflammation of the uterus, plus fallopian tubes plus ovaries plus your peritoneum. So PID is a very what do you say? Peritoneum. So PID is actually a very uh, painful condition, right? So most common route that you get your pelvic inflammatory disease is actually through intercourse, sexual intercourse, okay? And when you are having sexual intercourse, the chlamydia or neisseria, they enter through the cavity, okay? And enter inside along with the sperms. It is known as an ascending infection, right? It is an ascending infection, okay? Ascending in the sense it goes all the way up, right? It enters during the sexual intercourse, it enters with the sperm and it goes all the way up. That's why it is known as an ascending infection, okay? So what happens? There is first in acute PID, you get endosalpingitis. What endosalpingitis? Ophoritis, tubo-ovarian mass, pilosalpinx, and finally you get hydrosalpinx. Okay, these are all very painful conditions. What happens? Right? So endosalpingitis means on the what is salpinx? What is your salpinx? Can you tell me what is your salpinx? The pus that gets collected, pus starts getting collected here, okay? Pus starts yeah, your fallopian tube, right? So you have infection in the fallopian tube that goes all the way to your ovary, and then you have a tubo-ovarian mass which will start getting having a tubo-ovarian abscess, and after this you have an abscess, all right? And from the abscess you get pilosalpinx. So pus starts collecting, and that's how this whole sequence goes that way, okay? And the most common cause, again, it is due to intercourse, and the risk factor for this is multiple sex partners, okay? Multiple sex partners, because it's you're getting chlamydia or neisseria, right? These are STDs, okay? Multiple sex partners. What is the protective factor for this? Protective factors. How do you prevent yourself from getting PID? You use condoms and you use OCPs. Okay, very important. Condoms are very important. Okay, so the most common organism for this is actually your chlamydia. Okay, most common organism is your chlamydia. And what else? What symptoms do you see in this patient? What symptoms? Can you tell me the symptoms that you see in this patient? What clinical features, yes, symptoms can be seen in this patient? The very important symptom in this patient. Can you tell me? Yes, Alu, very, very important, lower abdominal pain. Okay, if you get a history of a female having multiple sexual partners, she has lower abdominal pain, then she's likely to be having PID. Okay, and she will always, since this is an infection, she will also have fever, malaise. Okay, it's an infection, right? That's why. So the diagnostic criteria is that she should have, a fever, she should have increased WBC, she should have fever, increased WBC, and the fever should be 101.1, point something, okay? But the fever should be around that much. She should have increase in WBC, increase CRP, because CRP increases in inflammation. Okay, if the body has inflammation, the CRP increases, and this is pelvic inflammatory disease, right? That's why the CRP should increase, and she should have a pus like discharge, mucopurulent discharge. Okay, and in the lab, like when we do lab diagnostics, right, she should have at least the organism in her discharge should be chlamydia or Neisseria. Okay, so these are the diagnostic criteria for PDID. How do you like definitely tell that uh, she has PID? You do a endometrial biopsy. Biopsy should be done. Okay, and on ultrasound you should have a tubo-ovarian mass. And what is the like gold standard for diagnosis? What is the gold standard for diagnosis? Can you tell me the gold standard for diagnosis? Your gold standard for diagnosis is your, what is it? Laparoscopy. Very good, Alua. Yeah, that's why CRP increases in COVID, right? Because there is inflammation in the body. Okay. So, what is the management in this? You do bacterial culture. You do culture. Okay. You do culture of the pus, of the discharge, basically. And then according to the if it comes as chlamydia or Neisseria, you use that antibiotic. Okay, you do culture first, you identify which organism it is, then you target an antibiotic against it. Okay, if patient, like, you also give ceftriaxone 250 mg IM. If the patient has come to the OPD, right, then you give them ceftriaxone 250 mg stat, and then you give them tap doxycycline. See, this can, they usually never ask you about the management. Mostly in PID, they'll tell you about, they'll ask you the diagnosis. So this patient, what this patient will present with lower abdominal pain, she will have fever, she will have malaise. When you look at the WBC, it's increased, the CRP is increased. So these kind of things, they will be given in the case. This will be a case-based scenario if they can ask you a question on PID. So they'll ask you this, and they'll ask you the diagnosis. tell me what is the diagnosis. So mostly in PID, that is the case. Okay, that is the question asked. And you can also give metronidazole. Okay, because these three work together very well. Okay, you can also give clindamycin and stuff, but again, management, more than management, or they can ask you, oh shit, I'm so sorry, my iPad iPad died. Let me just give me 1 second. I'm so sorry. Wait, just let me get it charged. I was in charge my phone. Okay, guys, so sorry. I'm so sorry. Yeah, okay. I'm so sorry, actually. My fault. I should have checked कि charge हो रहा है या नहीं. Are you guys with me? Can you give me a yes? Are you guys still with me? Can you give me a yes? Can you give me a yes if you're with me? Okay, great. So, so, okay. Okay, God. Okay, doctors, very good. So in chronic PID, what this was, we were talking about acute PID, right? So in chronic PID, right? The pain shifts, okay? Pain in abdomen is due to in chronic PID, can you tell me what happens? We will end the class in half an hour, okay? And the rest of gynae we will take in the next session, okay? Stretching, yeah, pain in abdomen due to stretching of the fibrous bands. Okay, there are fibrous bands formed. Bands, okay? So in chronic PID, you have, what do you have? You have stretching. The pain of the abdomen is in movements. When you do movements, the fibrous band stretches. That's why you get pain. Okay. So do you know about Fitz-Hughes syndrome? Fitz-Hughes syndrome. Can you tell me what this is? Very important again. Can you tell me what this is? Yes, very good, Jamut. It is pain in the right hypochondrium, right? Right hypochondrium. Okay, due to stretching of, yeah, perihepatic adhesions. Due to stretching of perihepatic adhesions. On ultrasound, what will you get? You get hydrosalpinx. Always in chronic PID, on ultrasound, you get hydrosalpinx. So if they ever give you a picture of hydrosalpinx and they ask you the cause, and in the option you see chronic PID, click on chronic PID. Okay? God, my whole body is, I think I got COVID because my whole body is paining and it's so bad. Okay. On laparoscopy, what do you get? On laparoscopy, can you tell me what do you get? Laparoscopy? Can you tell on laparoscopy? Yes, you get violin string sign, right? What are the complications of PID? You can get ectopic pregnancy complications. Okay, you can have ectopic pregnancy. If the fallopian tube is blocked, right? Partially blocked, you can get ectopic pregnancy, right? And you can also have infertility if it is completely blocked, right? So these are the complications of PID. Very important topic again. What kind of questions will you get? Either you can get an image-based question of hydrosalpinx, or you will get pain in the lower abdomen for acute PID. and you can also get the cause of PID, or you can get such kind of questions. Okay, yeah, infertility, if it is completely blocked, and if it is partially blocked, you have ectopic pregnancy, because the fallopian tube, right, it is not able to, the fertilized ovum will not be able to and go from the fallopian tube to the uterus. Okay, so what about genital TB? The next thing that we should learn about is genital TB. Okay, like we said, you get, it is you get, what do you say? Asherman syndrome is due to genital TB, right? So most common, it is actually a secondary infection. It doesn't start with genitalia. It starts from the lungs, right? You have a lung TB infection, TB. Okay, so it is a secondary infection. TBC, what is TBC? Genital TB is actually a secondary infection, right? So you get it from most likely the lungs. Okay, and most common route is hematogenous. Okay, from the blood it travels to the genitalia. Okay, right? Yes, most it is a, and this PID was an ascending infection. Genital TB is actually a descending infection, right? Why descending infection? Because you have seen that the PID goes from, it happens due to sexual intercourse, and it goes all the way from the vagina till your ovaries, right? But here in this case, it comes from the lungs, so it is coming from upwards to downwards. That's why it is a descending infection, right? So what is involved, like most commonly the ampulla of the fallopian tube is firstly involved in this. Okay, and the symptom that is most common symptom is your infertility. Okay, most common symptom is your infertility. And in if the female is still menstruating, she will have hypomenorrhea because of the additions. We already discussed this before. Okay, so what do you do? How do you do diagnosis? Diagnosis is done on the basis of diagnosis is done on the basis of your endometrial biopsy, right? See, Devashish, the hysteroscopy will be done after the endometrial biopsy. First, you do biopsy. Okay. Okay. So you do biopsy, and what you can, and then you take that and you can culture it, and then you'll come to find out if it is TB or not. So what is the management for this? What is the management? Can anybody tell me the management in this? Management in TB? Okay, management is you give anti-tuberculin drugs, right? Therapy, right? Your isoniazid and the rifampicin and all that. Rifampicin. Okay, so should we end or should we go to endometriosis? Should we end or should we go to endometriosis for today, and then we'll finish gynae in the next session? We have other things to discuss, but yeah, let's continue tomorrow because even I'm not feeling well. Yeah, let's finish it now and we'll finish. You revise till here. I'll put out a quiz in the group, okay, for till here. Okay, revise your cancers for the next class. Make sure to revise your cancers, um, revise your cancers, revise endometriosis, infertility, revise all these topics, okay? And then next later we will take OB, okay? Yeah. Thank you so much, guys. Thank you for attending the class. You take rest now, revise the class. Okay, let's meet for the in the next class. Okay, I'll end this session here. Okay, take care.